Ladies and gentlemen, thank you for standing by, and welcome to the CMS Tribal Affairs Call, Uncompensated Care Costs. At this time, all participants' lines are in a listen-only mode. After each presentation, there will be an open session. To answer or comment during the session, you will need to press star 1 on your telephone. Please be advised that today's conference is being recorded. If you require any further assistance, press star 0. I would now like to hand the conference over to our first speaker today, Dr. Susan Carroll. Thank you. Please go ahead, Doctor.
Thank you, Prince, and good afternoon, everyone. This is Dr. Susan Carroll from the CMS Division of Tribal Affairs. I'm welcoming you to a conference call with the Indian Health Service and Tribal Hospital Leadership and the CMS Division of Acute Care in the Hospital and Ambulatory Policy Group and the Division of Cost Reporting in the Chronic Care Policy Group. The purpose of this conference call is to learn from IHS and tribal hospitals about what uncompensated care costs they incur and any barriers to reporting those uncompensated care costs on the Medicare Hospital Cost Reports Worksheet S-10. As background, the Affordable Care Act established a new disproportionate share hospital uncompensated care payment by amending the historical Medicare DSH payment calculation. Effective for discharges occurring on or after October 1st, 2013, hospitals received 25% of the DSH amount they previously would have received prior to the passage of the Affordable Care Act. The remainder, equal to 75% of what otherwise would have been paid in aggregate as Medicare DSH, is available for uncompensated care payments after that amount is reduced for charges in the national percentage of individuals that are uninsured and other factors. In general, each Medicare DSH hospital now receives an uncompensated care payment based on its share of total uncompensated care across all hospitals, as reported on the Medicare Hospital Cost Report Worksheet S-10. For your knowledge, in the fiscal year 2020 IPPS final rule, the IHS and tribal hospitals' Medicare uncompensated care payments were not based on the S-10 worksheet, but rather continued to be based on an uncompensated care cost proxy using historical FY 2013 Medicare days and most recent available fiscal year 2017 SSI days. We look forward to hearing from IHS and Indian Health Care providers regarding the reporting of uncompensated care costs and any barriers to reporting on the Medicare Cost Report Worksheet S-10. Joining me on the call today is Mr. Donald Thompson from Medicare. Thanks, Don, for joining us, and I'll turn the call over to you and your team.
Thanks. So my name's Don Thompson. I work in the hospital payment policy area here at CMS, along with a team of individuals that are also with me in the room. And really, on today's call, we're looking for some input and some information to help guide future policy making around Medicare uncompensated care payments. And the two areas, and you can see it in the Save the Date attachment for those of you who have that in front of you, the two things that we'd like to dive into a little bit and hear from you. One is around sort of what charity care and non-Medicare bad debt that you could report to us on the Worksheet S-10 using the current definitions of those that we have, and those are listed there in the attachment. And then the second piece is once we have a better understanding of what uncompensated care costs that IHS and tribal hospitals have, is that are there any reporting barriers? So is there anything that prevents or inhibits the ability of the IHS or tribal hospitals to report that information to us on the cost report? So those are the two things that we're interested in. As part of that first question, it would be good to hear about Do IHS or tribal hospitals have charity care policies or financial assistance policies the way that other hospitals do? Because that's sort of one aspect of what we consider to be uncompensated care. So it'd be interesting to hear that. I'd also be interested in any information about how you track Medicaid co-payments and deductibles, even if you don't collect them. On the Medicare side, we're certainly able to tell from our contractors, our Medicare administrative contractor that works with the claims data on the Medicare side. We're able to determine sort of what the coinsurance and deductibles would have been, and I know at least for many hospitals, IHS and tribal hospitals, they are precluded by law from collecting the Medicare deductibles and coinsurance. Although, if I understand correctly, not all hospitals, not all IHS and not all tribal hospitals anyway. And then, so the ability for you to report the Medicaid deductibles and coinsurance would be of interest to us, because that's not something that we can get from our data. So with that, I think maybe the best format to work through here is the lines will open up, and if folks could call in, and then we'll just sort of work caller by caller. And if you could provide us input on the questions about what kinds of uncompensated care costs you have under sort of the current Medicare definition of uncompensated care costs, and then any barriers or burdens associated with reporting those costs. And we'll just work through and, like I said, have an interactive discussion here, and we're really looking to learn about these areas from the IHS and the tribal hospitals. So, operator, if you could maybe open up the lines, and if instructions on how people can call in, and we'll go from there. And also, by the way, if you have questions about this, it's not just, it's not just us getting input from you, but if you have questions surrounding any of this, we have a team of experts here in the room. Also, we have some cost reporting experts on the phone from CMS. So certainly, if you have questions surrounding those areas, you should ask those as well as providing us input with these. So looking forward to the conversations in the call, and turn it back to you, the operator.
Sure. To give input or to ask question, you will need to press *1 on your telephone keypad. And we have one on queue. Your line is now open.
Yes, this is from the Navajo Nation, and our question from the CEO is, employees of the Navajo Nation that are Indian beneficiaries are under a health insurance plan that is self-pay, and it's totally uncompensated with no reimbursement. Can we include that as our uncompensated care cost? It's non-billable tribal self-pay for all employees who actually work for the Navajo Nation.
So is there a charity care policy? Part of the Medicare policy surrounding uncompensated care, one aspect of it is that the hospital has to have a charity care policy or a financial assistance policy. And so does your hospital have such a policy? Has it ever considered sort of instituting one? If not, why? Or if you have one, does it include this? Those would be some of the questions. If you could give us a little feedback there on sort of, do you have a charity care policy or a financial assistance policy? Is there anything that would prevent you from having one?
We do have a very large and broad patient benefit center that assists the beneficiaries to get qualifications of Medicaid, Medicare, or SSI. We do have that section. This huge group of employees, though, fall under the federal guidelines that you're talking about in balance billing a proven beneficiary of the Navajo tribe, and these are all deemed self-pay when they come in. So we have been exempt from balance billing them through the nature of them being beneficiaries of the Navajo Nation. But there's been absolutely no reimbursement for that.
So, Tiana, maybe if you could maybe take a stab at explaining what a sort of charity care policy or financial assistance policy is. Maybe that's some of the confusion.
We're familiar with a charity and financial care policy, which is based on the income guidelines for the charity care. This is just a whole population of employees that are automatically deemed as self-pay because they work for the Navajo Nation.
Are they not eligible to enroll in a third-party insurance?
Correct.
So your employees cannot enroll in a Medicare or Medicaid or some other third-party insurance?
Correct, because they actually are employed by the Navajo Nation.
So then is their health care funded through Indian Health Services?
Well, right now there's no funding. That's why we're asking. There's no funding for this population of Navajo employees. It's totally uncompensated right now.
This is Dr. Carroll. Are these employees tribal members?
Yes.
And do the majority then go on to see their Indian health care provider at somewhere on the Navajo reservation at the Indian Health Service or tribally run hospitals?
Correct.
And so when they walk through there, they don't pay anything then, correct?
They don't, nor does the Navajo Nation compensate the hospital.
Right.
Why aren't they covered under Indian Health Services?
Because they're deemed as non-billable because of the nature of them being employed by the Navajo Nation.
I don't know, Dr. Carroll, is that some regulatory authority or is that a hospital's election? And I guess if it's a hospital's election, do they have some type of policy? Does it fall under what is considered charity care where the patient doesn't have the financial ability to pay, or does it fall under a bad debt where you're unable to collect? And it sounds like what she's communicating is not either that the hospital doesn't bill for those services because they're an employee of the hospital. It almost sounds like it's a benefit of, do you actually...
No, they're not the employee of the hospital. It's the employee of the Navajo Nation. Instead of it being like a county or a city, it's a huge nation, like a reservation that's larger. It's huge.
So when you're saying self-pay, they don't have to pay. You're just saying as a benefit of being part of the Navajo Nation, they receive their services at the hospital free of charge?
That's what's happening, and it's uncompensated just because they're all proven beneficiaries. They're all Indian Native.
Right.
So then what would come into question is that a fringe benefit of being an employee of the Navajo Nation and the benefit from the hospital, or is it truly an amount that you can't collect because they don't have the financial ability to pay?
Well, could the financial ability be the financial ability of the group that they worked for and not the individual? Because in this case, they're employed by the Navajo Nation. I know it's a different twist, but the CEO asked us to ask you all.
This is Dr. Carroll. I think this is not part of the realm of what we need to hear about. The patients are Indians. They receive free health care at the Indian Health Service and tribal hospitals, and that is different than what we're trying to understand from the Medicare and Medicaid standpoint.
All right, you're just wanting to know the true uncompensated as it relates to the charity guidelines?
Correct. And if you want, I'm happy to go over the question with your CEO at a later time. If they can email me, we'll provide emails at the end of the call.
All right, thank you.
Before you get off, though, in terms of the questions that we have, do you track, putting aside whether or not they would be reportable to us as uncompensated care, do you track the Medicaid deductibles and coinsurance, even if you don't collect them? Do you, or attempt to collect them? Do you track those, and would you be able to report those if asked?
We would if we had that population. We're in such an isolated area. We don't have HMOs for Medicaid here in this location of the country.
So you don't have much in the way of Medicaid deductibles and coinsurance, is what you're saying?
No. Mm-mm.
Got it. All right, that's helpful. Do you report anything right now on the S-10? Like when you submit your cost report, do you put anything on the worksheet S-10?
No, we fall under the information that you all provided, where if they're deemed Medicaid and Medicare and there's an out-of-pocket remaining and they're proven beneficiaries of IHS, we don't balance bill.
And of those people, it sounds like that's mostly Medicare and not Medicaid.
Correct. The only caveat we have on the Navajo Nation is we get a significant amount of Medicare Advantage folks that come through, and we're not members of Medicare Advantage, and that's 100% no reimbursement. And they definitely qualify for Medicare, but that doesn't mean that they qualify for charity income guidelines. And right now we're just absorbing that uncompensated care.
Right.
I don't know if there's a solution for the Medicare Advantage enrollees.
So the plan that they're enrolled in doesn't pay you anything?
No. Mm-mm. I mean, unless it's truly life-threatening and they come into our ED, but anything even through our ED that's not deemed life-threatening, and we do track all the uncompensated care that we're not getting paid for under Medicare Advantage plans.
Maybe Dr. Carroll, if there's something you could follow up with the CEO as well about exactly why that's occurring in a non-emergency situation, that they're so you don't contract with the managed care plan. These individuals seek services outside of facilities that have contracts with the managed care plan, i.e. your facilities, and because you're out of that and it's not an emergency situation, you just have to eat those costs.
Correct.
Where are you located?
We're only 75 miles south of the Utah border, in a very isolated area. We're 34 miles east of the Grand Canyon.
What's your service unit's name?
Tuba City Regional Healthcare Corp.
Okay. On the call is John Rayel, who is the director of the Office of Resource Access and Plan and Partnerships, and I've asked John to queue up for a question. I don't know if our moderator can identify Commander John Rayel by email so he can explain this to us a little bit more clearly. And he may not be able to get right in, but John is on the call, and we might hear from him in a second. Prince, can you check that? Yeah.
One quick question on the managed care. When you say you track the uncompensated care costs, how do you determine what those costs are? So for the patients that are coming in from the managed care that are that you're not paid for, how are you determining? You said you track what the uncompensated care costs are for those patients. How do you determine that?
We isolate that charge stream under unique insurance plans for those out of the nation, the folks that are coming through with the Medicare Advantage plans. We just track those uniquely by the names of their insurance companies.
Got it. So you use essentially your charges, your charge master to develop the charges associated with those for the care.
Yeah, we actually use our insurance plan master.
And for the ones that do show up in the ER that you can bill, that's how you develop the charges to charge the managed care plans when it is an ER situation. Same methodology.
Yeah, they just get charged what all patients get charged across the board. We can just track, though, the managed care, Medicare Advantage plans that they're presenting to us as their coverage.
Thank you. That was very helpful. I appreciate all the information. We touched on a whole number of different situations there, and hopefully some of those situations are also applicable to other callers. But that was great information. Thank you.
Thanks.
Next caller, maybe.
Hello.
Hi.
This is Elliot Milholland. Hi, Dr. Carroll and Mr. Thompson, Dr. Thompson. Just a couple of quick notes from your opening. Thank you very much, first of all, for having this call. I think it's very important. I'm an attorney, and I'm one of the technical advisors to the Tribal Technical Advisory Group to CMS. So there are a couple of kind of policy points that I think may inform the discussion. I'm hoping that we can get some more of the billing folks from the various hospitals to weigh in as well here. But on the policy side, a couple of points to make. You asked about Medicaid co-payments. My sense is that folks don't track those because American Indian Alaska Natives are exempt from all cost sharing under the Medicaid program. So they don't pay any co-pays or deductibles or any cost sharing of any kind in Medicaid. Similarly, for the Medicare program, the uncompensated care definitions that you've been using, at least as currently interpreted or interpreted to date, don't really match that well with how tribal hospitals report uncompensated care, because the hospitals, they are prohibited from billing the Indian beneficiaries they serve. So, for example, with Medicare, they don't balance bills. They're always foregoing that 20% of those costs. Same thing with the premiums and cost sharing. So, and that's really an uncompensated cost, for example, for Medicare enrollees. For others, they do receive funds from the Indian Health Service, but those funds are only about 50% of need. So there's a lot of care being provided, which is not funded by the IHS either. And so for individuals who have no other form of coverage, those are costs that IHS and tribal hospitals have to bear or have to incur, but they don't really neatly fit into the definition of a charity care, because a lot of those hospitals, they may not have that policy. They don't have a written policy necessarily that looks like the policies that other non-Indian hospitals have with regard to charity care, because their policy is they provide services to the American Indian and Alaska Native beneficiaries they serve, many of whom have no other form of coverage. Same thing with bad debts. They don't seek to recover against their beneficiaries because those individuals have a right to receive care through the Indian health system. So it's been kind of an apples and oranges type of thing. And so I'm glad that we're having the call and you can hear more directly on the policy side from folks like me, but really from the billing side to kind of get a sense as to how the billing folks at these hospitals are operating.
Kelly, I think, and I probably didn't explain it well earlier. Understood on the Medicare and the Medicaid deductibles and coinsurance that those are sort of under the current instructions, not something that they would necessarily be able to claim. But I was sort of asking, outside of the current instructions, do they track the Medicaid? So it sounds like from what you're saying, the vast majority of them don't. It sounded like I thought the Navajo doesn't have much in terms of Medicaid. It was much more Medicare. Even if they don't track it, it would be helpful if, as people called in, if they could give us some indication on what ratio they thought it would be. Like if they were to track them, do they feel it would be like 90% Medicare, 95% Medicare? It sounds like it's almost 100% Medicare for the Navajo Nation. But ideally, they would be tracking it, even though they can't report it currently. And if they aren't tracking it, a sense for the relationship between the Medicaid deductibles and coinsurance and the Medicare would be helpful.
Yeah, I'll just make more comments before I get off the line here. I'm not certain of whether folks are tracking or not. I just said that I think it's unlikely. Also, with regard to Tuba City, I do know that they have a lot of Medicaid patients. But I believe the caller there was talking about the HMO plans, the managed care plans that impose co-pays on and above what are exempt from having to be paid under federal law. So it's kind of a nuance there, but there is a Medicaid balance there too.
Thank you. Yeah, so interested to hear from the tribes on all these issues. Again, especially sort of the billing, accounting, tracking folks about sort of what you track and don't track in terms of uncompensated care costs. Again, either that would fit within the Medicare uncompensated care cost definition, or even what you track outside of the current definition. If there's anyone else in the queue.
Yes, John Real, your line is now open.
Okay, great. Yeah, we had a call with concerning the uncompensated care with the people that do our cost reports, and we'd had some interesting conversations concerning uncompensated care. And currently on the S-10, we would not be able to capture true uncompensated care, mainly for the reasons that some of the tribes are mentioning concerning the way we calculate our uncompensated care. We don't have policies for that. And really the fact that right now we just adjust. We don't have true write-off capabilities, especially when it comes to IHS federal facilities. We have adjustment codes, and we usually adjust just off coinsurance. There are some things that we do capture within our cost reports, but it's not some of the true uncompensated care that you guys are looking for. We have come up with several ideas, and that would probably would be a later discussion on maybe presenting some of those ideas to you. As far as the tribe, and I did hear Tuba City, and I think some of the concerns with tribal self-insurance is not only tribal members, but a lot of the tribes that have tribal self-insurance, they don't qualify for Medicare or Medicaid, depending on what's there, because they do consider that an alternate resource. And so even if they are tribal members, they don't get reimbursed for that, or we don't have the ability to bill for that because it is a tribal self-funded insurance. And those are some of the limitations with tribal self-insurance as far as getting reimbursed for that. So even though they may be within the service delivery area, they may not be PRC eligible, but they're going to utilize the tribal self-funded insurance for any outside care. But we do have several. We did have a great conversation with our contractor, who DS Douglas Sheets. They do our cost reports, and we did come up with some very interesting ideas on how we may capture some uncompensated care going forward. Harold Little also has some knowledge concerning the uncompensated care and what had transpired, and I don't know if Rahul Ortiz is on, but we did have some conversations with Harold Little as well concerning the history of the uncompensated care. But we were in agreement on how we would try to calculate that within our cost report that we do annually for our all-inclusive rate.
This is Dr. Carroll. John, I would like to recommend that maybe we can have another call with Carol and the contractors with Don at another time. I think we're really interested in hearing from the tribal side and the IHS hospital side how they handle their reporting.
Okay,
Thank
great.
you.
And we have more on queue. We have Susan Burris. Your line is now open.
I didn't have a question. Thank you.
Okay. And on the next one on queue, with no recorded information, your line is now open.
That might be me. I am from Southeast Alaska Regional Health Consortium. As our consortium's expanded, we've picked up a fairly significant population of non-beneficiaries. So we do have a number of patients who we should be collecting Medicare co-pays and deductibles for. We do have a financial assistance policy, and we would be able to track that information. So we would be very much interested in being able to report that on our cost report.
Is there any reason you don't report that now?
Our cost report preparers have told us that we couldn't as IHS facilities.
Yeah, Deanna, if you have any thoughts, I didn't think there was anything that would have precluded them from reporting for the non-beneficiaries.
No, nothing precludes them, but We could actually have a conversation with Peggy because they may have just not been doing it because it wasn't being used. I don't know. It's not a direction we provided. And I believe Peggy does the preparation of the cost reports for the IHS facilities.
Yeah, that would be great. Certainly, I would encourage all the IHS and tribally operated hospitals to be reporting on the S-10. There does seem to be some confusion on this point about perhaps that you're precluded from reporting, and that's not the case. So to the extent you have uncompensated care costs that meet the definition of uncompensated care costs, and again, separate discussion about what other types of costs folks might want to see included in there, at least to the extent you have costs that are reflected in the current definition, as is the case here with the Southeast Alaska, certainly you should be reporting those on the Worksheet S-10.
Thank you.
Is there another caller in the queue, or?
We have Melanie Forkiller. Your line is now open.
Hello, everyone. Thank you, Dr. Carroll from CMS, for having this call. I would, those that have talked about Medicare co-pays and deductibles as being those items that are discounted to us that we do not collect as being an issue, as well as the Medicare Advantage program from which we do not receive reimbursement at this time, although there's ongoing work to try to address that. So if there's any way to report those unpaid Medicare items, we would be interested in knowing that. So in terms of our other services, I am unaware whether we do the S-10 form or report, but of course we have an ER because we have a hospital. We have uncompensated care from there. We also serve a limited number of non-bins through the Tallahassee Community Clinic, which is adjacent to our hospital, as well as for some OB services, et cetera. So certainly we bill available resources as well as self-pay, but we don't always collect. So I would be interested in knowing whether we can file for uncompensated care for those items. So any information you can provide would be helpful. Thank you.
So under the current policy, the Medicare co-pay deductibles as well as the Medicaid are not considered charity care. On the Medicare side, the bad debt, if you were to attempt to collect them to the extent you were a hospital that had the ability to collect them, and I understand it's a small subset of hospitals that might have that ability. But if you could, on the Medicaid side, I may have missed that, do you track the Medicaid co-pays and deductibles that you don't collect or don't attempt to collect at your facility?
I'm not aware that we have a significant number of Medicaid co-pays or deductibles that are at issue because, as Elliot mentioned earlier, we do have a clear exemption for co-pays and deductibles for Medicaid. So I think that's less frequent a problem as the Medicare. So we've got that issue as well as the non-bins issue that was raised by someone in Alaska.
Meaning it's not a significant issue because you don't have many of them. So even if you were tracking them, it would not be a significant amount of money?
Not nearly as significant as the Medicare non-payments or deductions for co-pays and deductibles.
Got it. Thank you.
And we have one on queue. Please state your first and last name. Your line is now open.
Hi, this is Marty Wofford from Chickasaw Nation. I'm glad everybody's on the call today. You know, this is an issue that we've been talking about for several years, and it's my understanding that, you know, we haven't been required to fill out the S-10 worksheet, and that there was information that would be required there that, like you just said, that we wouldn't necessarily have access to or that our systems wouldn't be able to produce for us. As far as the question on the Medicaid co-pays and deductibles, I mean, we can run reports on that, but there are more to it than just that data. So I'm curious about being asked for that specifically. And then on the charity care policy that you were asking about, you know, I don't know that anyone on the call has had a charity care policy specifically.
Thank you. That's helpful. And on the charity care policy, is that just because it wouldn't be applicable, or what's the reason you don't have a charity care policy?
Well, in my mind, in the business that we take care of all of our eligible patients, which are all Native American or, with Native American child, we don't necessarily, we have a population that would have no resources, but that population is not charity care in the sense of the term.
Got it. So in terms of how Medicare uncompensated, for purposes of Medicare uncompensated care payments, how we define sort of charity care, you wouldn't have much that would fit within a charity care policy if you did have one.
True.
Okay, and so circling back to the Medicaid, I think the question you said you can run reports. So would those reports show what you would have attempted to collect from beneficiaries if you were allowed to collect deductibles and coinsurance?
We would not ever collect payment from our eligible patients at all.
No, understood. I meant, could you track, for example, on the Medicare side, we can tell even if the patients are not responsible for the Medicare deductibles and coinsurance, the Medicare administrative contractors can determine how much they would have been responsible for if they had been responsible for it. But we can't tell that on the Medicaid side. So even though you don't even attempt to collect or can't collect in the vast majority of circumstances, do you track what you would have collected or attempted to collect for the Medicaid is really the question I'm asking. So it sounds like from the majority of callers before you that it's not really a significant amount anyway, but for you, if you can sort of run reports that would indicate how much Medicaid deductibles and coinsurance that you would be able to collect if you were allowed to and you wanted to. Neither one may apply here. You may not be allowed to and you may not want to even if you were allowed to. But putting aside those two questions, do you have an ability to track the Medicaid deductibles and coinsurance for those patients?
Yes.
And is it compared to the Medicare? Is it, as other callers have mentioned, a much smaller amount?
I think in Oklahoma it's larger, but I'm not certain. I have not run those reports lately.
That would be interesting information for us to the extent you were able to provide that. I'm not sure what the exact mechanism would be, but when we can work with Dr. Carroll and others. But if you were able to sort of run a report that had your Medicaid and Medicare, if you have that ability to do that, or really anyone on the call, that would be useful information for us to have.
Okay, we can look at that and see what we can pull.
Okay, thank you.
Don, Rahu had shared an article earlier this week, and I wonder if it's an indication that Medicaid and CHIP insurance, there's no premiums, enrollment fees, co-pays, deductible, or coinsurance. So it may be that Medicaid doesn't apply it to their patients.
Well, that's an interesting question there for the individual from the Chickasaw Nation. So it sounds like from your Medicaid population, there are some deductibles and coinsurance. You track that by the state, what they would have charged, or is that something you calculate? How do you determine that amount?
I'll have to look at our reports and see exactly what it shows.
Okay. Yeah, that would be, to the extent what you're tracking and sort of where it's coming from. Some of this could be, it's making sure we're all operating out of the same definitions in terms of the Medicaid deductibles and coinsurance, because it sounds like from what Deanna was just saying, perhaps at least in some states, or there would be no way to track because it's never calculated or determined. That was helpful. Thank you.
Peggy Sheets is the cost report preparer for IHS.
Yes. Your line is now open.
Hi, this is Peggy Sheet. Just a few items to clarify. So on the S-10, we have not been completing that for IHS because of the proxy way uncompensated care has been calculated for them. And of course, we don't do them for critical access hospitals. So, that doesn't apply to them. Another quick item that I wanted to clarify. So for bad debt for a non-bin that would go through all the normal collection, we felt like we had asked via various methods if that could be claimed on the cost reports, and we were waiting for an answer before we claimed them on there. And Deanna clarified those we can claim as long as they meet all the audit standards and so forth. Another one of the barriers on the S-10 for the IHS hospitals is the cost to charge ratio, which is, it's going to flow over from Worksheet C. And we do a proxy to be able to settle the cost reports because the IHS hospitals do not have charges. So where you're asking for charges for charity care, even if it existed, even if the charity policy and so forth, if that were followed, then we don't have the charges to put it on. So there are big gaps in the way of trying to report anything on S-10 for IHS because of the charges. So what John Rael was talking about our conversation, and we were trying to figure out if we could claim the Medicare bad debts that, precluded by law that cannot be collected, net of any collections that were made. And we'd also have to verify and show when somebody is dual eligible, so they have Medicare and Medicaid, we would have to show that it was billed to Medicaid and that Medicaid denied that it would be paid. Although it's not going to be on there, that's probably not going to be that much money. But we, in our preliminary looking at it, it looks like IHS would be made whole with this. So the bad debts would go on the E-Series and be reimbursed, and then the portion that Medicare doesn't pay, because Medicare pays 65% of the bad debts, the 35% would flow over to S-10 in the usual way that it works, and maybe you would get what the information that you need for a good S-10 without any special considerations for IHS. And then they would still get at least the amount of uncompensated care that they're getting now with this proxy of the using the Medicaid days.
Oh, it sounds like you're saying on the Medicare side, you would attempt to collect, or you're saying that if we allowed you to count that even if you didn't attempt to collect?
Right. We cannot collect. It's against the law to do that. I don't think any of the tribal organizations, I don't think they have a policy of trying to collect from anybody. And for IHS federal hospitals, it's clearly stated they cannot try to collect. Likewise, there's no cost sharing with Medicaid, including, as Deanna said, with CHIP and so forth.
Right, understood. So it sounds like under the current definition, I mean, putting aside the issue which I think we've clarified, which is that people can and should be reporting on the S-10 under the current definition, and it sounds like there may be some costs that IHS hospitals and tribal hospitals could be claiming, maybe not a lot, but some. The recurring theme I'm hearing is that the Medicare deductibles and coinsurance are one of the largest drivers for what people would be able to report on the S-10 if they could, which again, they're precluded under the current definition, but if they could, it sounds like you're also saying that would be a significant amount. I mean, you're breaking it up into the bad debt and then the uncompensated care.
Right.
Whether or not there'd be some other way to approach that, we could have a separate discussion. But certainly, it sounds like you're saying that the Medicare deductibles and coinsurance could be a significant amount of money, at least for many IHS and tribal hospitals.
Right.
And those
in
amounts.
fact, all these years, it's not been allowed to be claimed.
And that's still true, by the way. That would be the case but essentially it's not the patient's responsibility, and I think that's been the barrier to allowing those deductibles and coinsurance to be claimed. Did I get that right, Deanna?
Yeah.
Thank you, Peggy. That was helpful. Good background information from us. And again, maybe we will set up a separate call about some of the brainstorming ideas that folks had about what might constitute uncompensated care aside from the current definition.
Okay, that sounds good.
Is there another caller?
We have Ryan Douglas. Your line is now open.
Hi, this is Scott Stramka and Brian Douglas. We're both Peggy's partner. I think she covered most of the stuff that we wanted to cover. Just that when the proxy was established for IHS, we were under the impression that that would go on and continue until about a week or two ago, when we were asked to be on this call, and kind of got the idea that you're trying to move towards using the S-10 rather than the proxy that's been established year after year. And so we haven't really requested the data or tried to put it on the cost report, and mainly because of the things that folks have said already is they can't bill for the deductible and coinsurance for a Medicaid or a Medicare beneficiary, and so they really haven't created a robust charity care policy, because it would essentially be a waste of their time, because they can't get reimbursed for it under any mechanism. And so I think, the answers to your questions here, question one, yes, they do have some unique uncompensated care situations, and then they also have some uncompensated care situations that would fit within the current guidelines of Worksheet S-10. Whether they have a policy that they can pull out of a file cabinet and hand you, maybe not, but it's certainly something I think they all could maybe work towards. And the second question, there are plenty of barriers to trying to fit how IHS facilities are being operated and how they collect and how they do not collect revenue into the S-10 calculation, and namely the cost to charge ratio is one of the big drivers of that, and then not reporting charges is also an issue. So that's about all I wanted to add.
Yeah, appreciate that. And just to, you had mentioned Medicaid as well. So would you agree with sort of most of the previous callers that most of the dollars, if you will, are on the Medicare side and not the Medicaid side?
It's definitely going to be more. I hate to put a number on it. I know everybody has kind of said not that much, but I'm not sure what not that much is. And so I would hate to try to minimize it or quantify it at this time, but
got it. So more Medicare than Medicaid.
Definitely.
The Medicaid amount might differ by facility, not zero, but hard to quantify sort of how much less than the Medicare, and it might vary by facility, but unlikely to ever exceed the Medicare.
Yeah. So I think those things exist. I just think that typically IHS facilities, they're rural, they're hard to get employees out there, so they're not going to start tracking something that they're not going to get reimbursed for. So I think it's there. I don't think no one's tried to quantify it in the past.
And I think, again, we sort of clarified the part about not reporting, but maybe bears repeating that there's nothing precluding an IHS or tribally owned hospital from reporting the Worksheet S-10, and to the extent you have anything that is reportable under the current guidelines, you should certainly be doing that, and would encourage folks to be doing that, and understand sort of the confusion about the use of the proxy. And again, it certainly is understandable how someone might have connected the use of the proxy to some relaxation of the cost reporting requirement, or even a preclusion from the cost reporting requirement. But again, that is just an area of confusion. That was never the case. And just as a bit of history, so everyone had the proxy when we started. So it wasn't a proxy for IHS. Was a proxy for all hospitals. All Medicare hospitals had the same proxy methodology. And what's happened over time is that we have moved to the Worksheet S-10, and one of the sort of last remaining groups that is still using the proxy, which again is based all the way back in data from 2013, at least partially, which is problematic for us. So one of the last remaining groups that's using the proxy are the IHS and tribally owned hospitals. So one of the motivating factors sort of behind this conversation is for us to learn as much as we can about the IHS, just exactly what people have been telling us has been invaluable about sort of what uncompensated care costs they face, what are the issues. So as we think through sort of how to move off the proxy, because it is using such dated information, as we think through that, this can help inform us as to what alternative policy options might be, which is, one of the reasons that we would certainly encourage folks to be reporting what they can now, and then we can continue to have this dialogue about other types of uncompensated care that might be unique to IHS and tribal hospitals that we want to consider.
So would you suggest that we report only charity that would comply with the regulations as written now?
Until we were to change something, it would be under the current instructions while we sort of use all the information we've been gathering and will continue to gather about what changes might be appropriate in this context. At the minimum, you should be reporting the amounts that you can under the current definition.
Okay. So the federal facilities, it's probably not going to be anything at this point. The tribal facilities, many of them, they use a different billing system and can generate charges. But whether they have a charity care policy written and following that policy, if those two things are true, whatever charges would apply to that population, then we should start reporting. If they don't meet the first two, where they don't have a policy, then we shouldn't report anything at this time.
Correct. And to the extent folks haven't developed a charity care policy or as robust a charity care policy as they might have, again, because maybe some of that confusion over the proxy, there's nothing preventing a hospital from developing a more robust charity care policy that might include some things that they hadn't really thought about before because of the existence of the proxy.
Okay.
That was helpful. Thanks, both of you.
And we have one more on queue. Please state your first and last name. Your line is now open.
Hi, this is Dennick McDonough. I'm a technical advisor to TTAG as well. And excuse this basic question so late in the call, but for purposes of uncompensated care calculation, how is an IHS eligible individual who is uninsured treated in the calculation?
IHS eligible individual who is uninsured. So would they be covered? Is the hospital in question or the facility in question, does it have a charity care policy or a financial assistance policy? And would the individual be covered under that charity care policy or financial assistance policy?
So this is a tribal hospital. And for IHS eligible individuals of any income that do not have insurance, the hospital eats the full cost. How is that cost related to that individual incorporated into the uncompensated care calculation?
So Deanna can chime in, but it has to have a charity care. So in other words, to be considered charity care, it has to be provided under the hospital's charity care policy or financial assistance policy. So if the hospital doesn't have a charity care policy or financial assistance policy that describes the situation for that individual, then under the current definition, that's not claimable. But if they had a charity care policy or financial assistance policy that covered that individual in this situation, then yes, if covered by the charity care and assistance policy and that care was not otherwise compensated, they would be able to claim it. Again, assuming the care is not otherwise compensated, which gets into a bit about the IHS appropriations and other issues. But to the extent it's not considered compensated care and it's the individual's covered by a charity care policy or a financial assistance policy, then that would be claimable. I am not the cost reporting expert, but anything to add to that, Deanna, or correct?
Well, I guess what's a little tricky about this is that my understanding is the Indian Health Services are funding the hospitals. All of the beneficiaries are encouraged to seek health care insurance in addition to, but those patients that are paid under insurance, the hospitals are all part of contracted health services, correct?
Well, let me maybe focus this a little bit more. So this situation, Tribal Hospital, it happens to be located in a state that has not expanded Medicaid under the ACA authority.
Okay.
It has uninsured rate nearing 60%.
Okay.
So let's focus maybe on the issue of and otherwise not compensated. So how is the allocation of IHS funding, federal congressional funding that goes to a hospital, how is that amount determined to be whether it is offsetting the costs of those IHS eligible individuals?
So I don't know how the amount is determined. I was looking in the recent regulation under 136.30 that speaks to the beneficiaries that are covered under a third-party insurance. I don't know enough about how the IHS funding occurs for each hospital, but it seems to indicate that it's supposed to be there for these costs that you cannot bill the beneficiaries for.
Okay, so just honing in on that, that's exactly the point, and what I may have a misunderstanding, but is effectively are the IHS eligible individuals' costs at a tribal hospital excluded from the calculation for uncompensated care, with the understanding or expectation that the IHS appropriation, whatever amount that might be, whether it's $5 million or $50 million for the hospital, is adequate to cover the costs, and so there is no uncompensated care to the facility for the IHS eligible individuals?
That's one of the things we've been struggling with about is sort of what's covered by the appropriation, and we've been working with folks here to try to understand that better. It is certainly the case that to the extent care might be perceived as undercompensated, that is a different issue from uncompensated. So to draw an analogy in a non-IHS context, we have often heard from hospitals that they consider their Medicaid payments in their state to be undercompensated. Therefore, anything that is below what they perceive to be full compensation is considered to be uncompensated care. We have not accepted those arguments. So the issue really comes down to the connection or lack thereof between the IHS appropriation and the waiving of the deductibles and coinsurance, and that's one of the things that we've been trying to better understand.
Okay, so I really appreciate this call, but I think there's two buckets. There's how do we do the calculations, make sure we're not missing anything as they're currently constructed, whether there's co-payments that are there that can be incorporated in uncompensated care, when does that occur, what have you. But I think possibly the bigger issue is this assumption that for the IHS eligible population, there's a funding stream that eliminates uncompensated care to the facility. So if I were just to give you one example, maybe I'll overly simplify it, but a tribal hospital in a location and it has 60% of its patients uninsured, it refers out a lot of care to other hospitals because it doesn't provide the full range, not unusual, but particularly specialty, what have you, doesn't have it. But even some of the basic services aren't at the hospital because of inadequate funding. But it's not able to refer out all of the people who need care. In fact, there's probably half of the services that are would be defined as medically necessary under a basic insurance plan are not referred out because of the inadequacy of the funding. So if you put together the referred out and provided in-house, you really have a deficiency of funding for the IHS eligible population. But for purposes of uncompensated care, it's thought of, those folks are fully funded, don't need to worry about them. It really it varies from hospital to hospital and Medicaid expansion state, non-Medicaid expansion state. There's at least 12 states that have IHS tribal facilities that have not expanded Medicaid. So you have a real intensity of this problem of a lack of adequate resources, particularly in those states. So I wonder if it would be doable to put on the table the second question, in addition to using the right form and putting the right numbers, but addressing this issue and the assumptions that may go with it about excluding IHS eligible individuals if there is any IHS appropriation coming into the facility. And I think you raised a really good question about the Medicaid example. Is that comparable? Where you could spread out the IHS dollars and say, well, we got $1 at least for everybody, so it's the amount of reimbursement from the feds may not be enough, but it's going to knock you out. But that really wouldn't, as a good policy, that wouldn't make sense. I think we got to look at IHS tribal hospitals in the aggregate. What's going on? Is there uncompensated care? Is the amount of funding coming in to subsidize uninsured IHS eligible individuals adequate? And if not, how do we adjust the dish formulas so that they work and we don't just put aside these hospitals and assume everything's adequate? I realize you don't want to spread resources across the board in a way that's not effective, but you have some really, really, really intensely under-resourced hospitals that get very little uncompensated care adjustments because of the assumption that the population that's uninsured, and the one I'm talking about is 60% uninsured in this state because of Medicaid so low, and there's a lot of small employers where people work. That combination that creates that huge uninsured and really inadequate ability to meet the services either at the hospital or to refer out elsewhere.
I appreciate that, and I think you've definitely put your finger on one of the key policy components of this. I think one of the challenges for us is that the issue of the adequacy of the IHS funding, the policy question there is the Medicare uncompensated care payments from the Medicare Trust Fund a tool or mechanism, appropriate tool or mechanism to address issues with respect to IHS appropriations? And the reason I raise that question is that the Medicare uncompensated care payments are fixed. The total amount that we can pay out nationally is fixed. So to the extent IHS hospitals get increased payments, what that means is that every other hospital in the country gets less. So it's not an open-ended system. It's a zero-sum game. So to the extent one believes, just hypothetically speaking, playing it out, that the IHS appropriations are insufficient, is the correct policy in response to that to remove money for uncompensated care from other hospitals nationally and provide it to IHS hospitals to offset undercompensation by the IHS appropriations process? Or are there other tools that should be done and brought to bear and used to address perceived inadequacies on IHS funding? That's sort of, we're a little far afield from this call, what we were trying to get in this call, but that is at a global level the issue. So if Congress has decided there's a certain amount of money for uncompensated care nationally that CMS is allowed to provide, and we're supposed to provide that according to a relative uncompensated care measure, in other words, comparing apples to apples, uncompensated care provided by all the hospitals across the country, if you have an orange in that mix, in the case of sort of some unique circumstances for IHS hospitals with respect to the IHS appropriations, is or is not the fixed Medicare uncompensated care pool, the correct tool to address those. That's the largest global policy issue, and that's what you've put your finger on, which is, again, I agree, separate from the issue of sort of Medicaid and Medicare deductibles and coinsurance. You're asking a much broader question about the role of the Medicare uncompensated care payments relative to the IHS appropriations.
Yeah, that's a great question. And I mentioned earlier you have funds available that you want to target to where they're needed the best. You want to spend those wisely.
That's actually not true. So we're doing what the statute requires us to do. These are not targeted funds. So these are not discretionary funds that CMS can choose to direct in one direction or another. The law requires us to distribute those funds according to relative uncompensated care burdens from hospitals. So these are not sort of discretionary funds that we're targeting to meet need, that we can sort of from a discretionary standpoint direct in one form or another. So just wanted to clarify that for the people on the call. We are required by the statute to allocate this fixed amount of funding according to relative uncompensated care costs across all hospitals. And so it's not discretionary and it's not targeted in the sense I think you were using the word there.
And excuse my lack of depth on the new Medicare uncompensated care policies. Is there a dictate, though, in federal law that requires exclusion of IHS eligible individuals in the calculations?
The question is whether or not that care is considered uncompensated. So to the extent that care is compensated, then yes, there is a statutory prohibition on us counting compensated care as uncompensated for purposes of allocating the funds. To the extent that care is uncompensated, which is the question we've asked about the relationship between the IHS appropriations and the Medicare Uncompensated Care Fund, so to the extent that care is uncompensated, then yes, the uncompensated care would be appropriately paid for under the Medicare uncompensated care payments.
Okay, take all the time here. Just on that last point, and maybe this could tee up for subsequent discussions and directly addressing the challenges that you've mentioned in terms of fixed pot of money and what have you, is it doesn't sound like that there is in federal law that they set a policy so that we need to disadvantage IHS and tribal hospitals. And I'm not saying that in a derogatory manner. I'm just saying to exclude them or discount the uncompensated care that they have. And so I think it really is worthwhile, and it would be consistent with federal law that to implement it, that the uncompensated care at tribal and IHS hospitals has to be considered, even for IHS folks. The formula to determine whether it's already compensated by the appropriation is worthwhile to figure that out. But a blanket, a wholesale, putting all these folks aside, because just to use one example, one hospital is unable to provide care to these individuals because of inadequate funds. When it doesn't have the specialty on site because it doesn't have the resources, and is unable to fund through contract health services, are now called purchase referred care, that is the clearest indication of the inadequacy. The non-ability to fund a PRC referral to fix a significant medical issue. It can't be any clearer, and it's 100% unfunded because it's 100% not referred out for that individual who has to wait in line to see maybe the appropriation next year or the next month is going to be enough for those individuals. So I just want to put a pitch out there that actually we really should look at this issue because there are facilities that have substantial unmet need, and Congress did not say exclude them because they can go argue with the appropriators about the direct appropriation.
Certainly agree that any uncompensated care costs faced by IHS hospitals should be part of the Medicare uncompensated care payments. I think we're in total agreement on that.
And this is Dr. Carroll. Don, we're at the hour. I'm sorry to interrupt, and
Sure.
I want to wrap things up. I greatly appreciate everybody taking time today. Apologize for any of those of you that are on the queue waiting, but it is 5 o'clock, and we want to be respectful of everybody's time. We've heard some great comments from everyone. We appreciate everybody taking the time to comment, and we can do another call if we need to. So, Don, I don't know if you have anything else to add.
No, it was good. This is great. And I think it was great in the sense it ranged everything from sort of very detailed questions about individual circumstances, starting out with the Navajo self-pay employees, the non-billable, everything up to sort of the broader policy issues with respect to uncompensated care. So I think it was a great discussion with a wide range of issues, and we took a lot of great notes. And again, we may, to the extent we need to come back, certainly would be open to doing another call, especially I apologize to anybody who was in the queue that we didn't get to. That was certainly not the intention as we had the broader policy discussion. Again, apologize to anybody who wanted to add anything. But if you did, I'm sure there are, Dr. Carroll, there are mechanisms for folks to provide input that were in the queue that weren't able to get through. Is that something that you guys could facilitate?
Definitely, Don. We have people can definitely email myself, susan.carroll@cms.hhs.gov. We also have a Tribal Affairs listserv, Tribal Affairs at cmshh.gov, and we would be happy to hear from anybody and everybody who is listening to our call or after discussions with your CEOs across the country. Please do email us with the answers to those 2 questions from the save the date and any other information. We serve a role to provide liaison to the Centers for Medicare and Medicaid, and we want to thank Don for reaching out to us to ask us these questions, and we hope everybody will take this back, discuss it further, and we know we will hear more, and please do email me. So thank you all, and have a good evening. We look forward to our next call with everyone. Thank you.